Hi, welcome everybody to our weekly CCDD ID Epi Spring Seminar Series. I'm really excited today to introduce Professor Menzies. Professor Menzies is an associate professor of global health in the Department of Global Health and Population and part of the core faculty of the Harvard Center for Health Decision Science and the Harvard Center for Communicable Disease Dynamics. Professor Menzies uses decision science and quantitative research to understand the consequences of policies to combat major infectious diseases and help design effective disease control programs when resources are limited. Great, I'll give you the floor.
Thank you very much. And that's on. I was lucky. I think we're good. I guess we should check someone on Zoom. Can you indicate in some way that if there is someone on Zoom
we
that
hear
you can hear
you.
this?
You're great.
Oh, and we hear you very well. That's good. Okay, I'll get started. So the question today is who has TB? So to start off with, this is a talk about tuberculosis. I think we had a talk on TB already about 2 weeks ago, so hopefully you all are familiar. TB is an infectious lung disease caused when someone talks, coughs, spits, expectorates in some way, and some sort of bacteria, including a small droplet nuclei, breathed in by a susceptible host, and that individual can go on to develop clinical disease themselves. This is also a talk about mathematical modeling. Again, a lot of people in this room will be familiar with mathematical modeling. This food processor is actually a very poor model for modeling, which I'll talk about in a second, but think of some process where we take data, published evidence, like sort of as recorded in sort of studies in a journal, or if we don't have any of those things, we'll pull in some expert beliefs, what we think might be the case. We have a model which we use to combine them. And from that process, we can get inferences about some stuff we're interested in. It could be inferences about disease natural history, about epidemiological trends that we're interested in, about the impact of different policies we're looking to compare, like lots of different types of uses for modeling. The reason why I say this is it's like an inside joke, it's a bad model for models, is that what a food processor does is it takes these ingredients and sort of separates all the connections between them, right? You put a banana in a food processor, it does not come out looking like a banana. We've sort of separated all the things that held it together as a banana. For our models, what we actually want is we want to maintain the connections. Indeed, what our models typically do is they express our beliefs about the connections between the different input data. So we can think of a model as sort of taking observations about the world and taking beliefs about how those observations fit together, and taking both of those two things allow us to make these inferences. So with that background, I want to thank a lot of people. I realize this is being a little bit lazy. I'm just thanking everybody, but a lot of people contributed to the analyses I'll be showing you here. So students, trainees, fellows, colleagues, and collaborators, both at Harvard and different institutions. I think the educational and support staff who often don't get enough play, I think, in these kinds of thank you slides, and also research funders. Long may your work continue. So the problem, this is the haystack, right? So there's 8.3 people living in the world. I had to go Google that. We are interested in the fractions of the portion of that sort of sphere that have TB disease. Okay. One thing we can start with is the number of people who have ever been infected with Mycobacterium tuberculosis, which is the causative agent in TB. One estimate is that there might be about 1.7 billion of those individuals. So that's coming from a study conducted about 10 years ago, which estimated that about 23% of the global population might have what was at the time called latent TB. Right, so 23%. Adjust that down a little bit because TB transmission is slowly going away in the world if we sort of cross our fingers, and then multiply it by 8.3 billion and gives us 1.7 billion. Okay. Now I said what was at the time called latent TB infection, and I said air quoted it a little bit because our understanding of that part of TB natural history has changed in recent years. And so a recent kind of reanalysis by a lot of the same investigators came up with a much smaller number for the number with TB or TB infection. And this comes back to how we understand what happens after an individual is infected with MTB. So this is a model schematic from what is, I think, still the most highly cited TB modeling paper. So this is a paper by Amelia Vinicki and Paul Fine, published in 1997. And the key thing about this model that I want you to focus on is this compartment here. So if someone gets infected with TB, right, they go down this arrow, they're not lucky enough to develop immediate immunity, they're in this latent TB state. Those in the first 5 years after infection have higher rates of progression to followed people after infection and seen that those where we see that they sort of seroconverted from, not presumably having TB infection to having TB infection, that, in the years following that seroconversion, incidence rates are a lot higher than they were sort of 5, 6, 7, 8 years afterwards. So we know in the short term, TB incidence rates go down. But if you survive that 5 years without TB, you fall into this latent compartment, and there you stay. The things that take you out of that compartment are development of TB disease. And so these different arrows are sort of different ways of developing TB disease, or you die. That's it. So this is like this persistent latency kind of model. Now, in recent years, there's been sort of more and more data accruing to suggest that, there is no such thing. There isn't this durable latent infection that you're kind of parked in that state until death or active disease. One sort of, factoid that contributes to this is a study we did with the CDC, led by a PhD student, actually at the time, master's student in my lab, where we looked at the US TB notification data. So there's people who are diagnosed with TB in the US as a function of age. We're looking at people born within the United States, just because if we looked at them, we had a reasonably high sort of confidence that, if a fraction of that population immigrated, it would only be a small fraction. So we're kind of looking at an almost closed population. We know when people were born because that's recorded in the TB sort of notification data. And therefore, we can track cohorts over time to understand what are the incidence rates within these cohorts, age on age, as they get older. And you can see this sort of raw data in this top panel. Each line represents a birth cohort. So down here, we're looking at the 1911 to 1915 birth cohort. We don't get to follow them for very long. But, as we look across the graph, we're seeing some older and older birth cohorts. And this is the TB incidence rate. All of these lines are sloping down. Like you can think, maybe there's something going on up here. It's very hard to build a model of TB with this persistent latency idea where you'll get all of these incidence rates sloping down, right? Because if people have persistent latency, and if most people who have TB were infected a number of years ago, and certainly for the older US population, they're not really getting infected right now. They were infected when they were young. You would see very flat lines. Again, this is now our sort of regression adjusted estimates. You can see all of these lines sloping down, suggesting that in this population, so the risks of developing TB due to some historical TB infection is kind of leaking out of the population over time. One thing you could say is maybe some of that is actually recent infection, even though we don't know. Maybe these people are getting infected. And so as transmission rates go down, then incidence rates go down. We were able to look at the subset of people who were not attributed to recent infection. So in the US now, they do genomics on all the TB cases. And so we can see sort of subset of a set of people who there was no recent source case. So this is a stronger evidence that they were infected historically rather than recently. And again, you can see these lines sloping down. Like less data here. We only had about 7 years worth of data for this genomic data, but still sloping down. I mean, one could also make a healthy survivor argument, right? That the people who have TB infection are dying off faster than the people who don't have TB, which could also lead to a sort of declining trend, but it would have to be a relatively huge healthy survivor effect to explain these data. So again, this is circumstantial, but with this and other data, people have come to believe that, TB infection is not necessarily for life. So if we go back to this sort of old model, this is representative of the new model. So here in this model, this is a model used to study the impact of new TB vaccines. They have these TB infection compartments, but critically, they've got some rate of sort of exit to a compartment where people might still have some partial immunity to new infection. We know that if you're infected with TB once, it does confer some partial immunity. Or I say we know, we believe, but no risk of ongoing disease. So again, we're allowing for TB risk to kind of drain out of the population. The idea here is we want to have a risk of disease that looks something like this. So this is some years since infection. This is TB risk on a log scale. Immediately after infection, we have relatively high rates. Those rates decline pretty quickly. Again, we have empirical data for this bit, but the sort of new evidence is suggesting we have this ongoing decline. So that if you have someone infected 60 years ago, it would be a huge surprise if they were to develop TB due to that infection 60 years ago. And this is to get away from the sort of red line, which is what the old model might suggest, right? Declining initial rates, but then a plateau at some rate where, again, at 20 years or 60 years, there might still be the same rate of TB. So we want to do away with that. Okay, so if we build in that idea, and that's what this study tried to do, we now have a much smaller estimate of the number of people who now have viable MTB infection. That is, it could cause TB disease. Now, if you remember the title of this talk, you will think, well, yeah, but that's not necessarily TB. We're interested in the fraction with untreated TB disease. Interestingly, that's actually easier to get to than some of these numbers, in that we could take the current global estimate of TB incidence of about 10 million people developing sort of TB disease per year. We know that the duration of TB disease, we believe from some historical evidence that the duration of TB disease might be between 18 months and 6 months, depending on your country. So if we just assume it's 1 year, then if you have 10 million incident cases per year, you'll have 10 million prevalent cases in the same year, under some equilibrium conditions. So if you put that together, that means about 0.01 billion people with TB disease. It took me some time, but the areas of these blobs are accurate to the numbers shown. I actually thought this blob would be like tiny. I was like, people won't be able to see it. But turns out this is 1 to 830 scale. It's about right. So this is the needle, this is the haystack. We want to identify these people with TB disease. We know have high mortality rates during the episode. And as you'll see later in this talk, they also potentially have high sort of or ongoing burden even after cure. It's better to get them on treatment earlier. Okay. So we have this group. If we zoom in more closely, we see a lot of variation. And again, sort of historically, we might have thought of TB disease as this single group. If you look closely at some of those models I showed you before, they would have a single TB disease compartment. In reality, we now know that there's no such thing as kind of stable TB disease. And so this is a plot of showing the different sort of phenotypes of TB disease you might see. Some people will get infected and develop TB disease relatively rapidly, what we call primary TB disease. Some people will, have TB infection, maybe not develop TB in the first year or 3 years or 5 years, but say 8 years later might develop TB and progress relatively rapidly. Some people sort of develop kind of grumbling TB, where they'll be symptomatic for some points, then they'll be asymptomatic, still have TB, and then, they'll be symptomatic potentially again 3 months later. Here on the vertical axis of showing severity of symptoms. Okay. And so the closer we get to it, the more complicated it is, and also a lot more kind of, small differences between these different categories. These are not clear categories. These are this is a continuum of disease. More and more we can think about it in sort of two dimensions, where if we think about all pulmonary TB disease, we've got classical TB. Everyone would think about TB in this way. These are people with symptoms. They've got a prolonged cough, night sweats, fever, they're losing weight, they're feeling poorly. They also, when they, we ask them to expectorate and we sort of culture, to see if there's anything in that sputum. We would have culture positive TB. So this is how it's kind of easy to think about TB. We also know that there's a lot of people who will have TB symptoms, prolonged cough, all those things I said, but they'll be culture negative. Even in the United States, where we will do a lot to diagnose the conditions people will have, and we'll do a lot to confirm those diagnoses. Even in the US, amongst all TB notifications, only 80% are positive on the bacteriological tests performed on those individuals. So the remaining 20% are what's called clinically diagnosed TB. We try to test them with these tests, but they are negative. Yet they might be a contact of a recent case. So we know they've got exposure. They're feeling sick. They have, on X-ray, we can see signs of TB disease in their lungs. And we certainly have TB, but they're culture negative. This side of the diagram is a little bit newer. The idea that there'll be so many people potentially who will have symptom negative TB. That is out in the community, not seeking care. Potentially if we do a culture on them, we'll find that they have TB disease. And indeed, that's what a lot of research has done in the context of TB prevalence surveys, particularly the recent ones. So the ways you can get tested for TB is either you describe TB symptoms, prolonged cough, that kind of thing, or they'll do X-rays of everyone and find, any X-ray signs suggestive of TB. And those two groups of people are tested for TB. They'll either have a culture or a cartridge-based PCR test or sputum smear microscopy. There's various tests we will use. Those studies actually find a lot of individuals who do not report any TB symptoms, yet have X-ray signs of TB and then sort of are culture positive. So many more of these individuals in the world than we would have previously thought. There's also this group, which is a little bit like the dark matter of TB in that they don't have any of the things we would use to find them. So do they exist? There are studies which identify people who have X-ray signs of TB, people who are not reporting any symptoms, people who are culture negative, and yet in those cohorts, if they follow up a year later, about 10 to 15% of them will have developed clinical TB. So there is a thing here, obviously kind of hard to deal with just because, again, they don't sort of express any of the signals we would typically use to diagnose them. Okay, so that's well and good. We've now expanded our understanding of TB. This has been a pain for the WHO in that, previously they'd thought about TB disease as being that smear positive kind of, this group here or maybe this group here. But now if we know there's a lot of people with asymptomatic TB, we need to include them in guidance. And so this is results of a report that came out following a consultation in 2024. So saying, yep, we realize there are people with asymptomatic TB. Some of them will be what they call bacteriologically confirmed, which is a misnomer. It's a bacteriologically confirmable. Like, this is not saying they had a test and they're positive, but more if we did a high sensitivity test, they would be positive. And then there's also this group, the asymptomatic bacteriologically unconfirmable TB, which is that dark matter I mentioned on the last slide. So they're saying, yep, they exist. This is how we define the world. And honestly, they're still working on how to sort that out in terms of their estimates. So we've established these, categories. As to how people move between these different states is a work in progress for the field. And so, there's a number of studies which have started looking at it. This by Tess Rickman, David Dowdy, and Emily Kendall, published in 2022. So really drew the 4 boxes I described on that last slide. So breaking up all TB into symptomatic and asymptomatic, and then in this case, smear positive or smear negative. Smear, a less sensitive test for TB than culture. This is a study by Catherine Horton. This is a study by Catherine Horton. Less health states here. So now just breaking up TB into these 3 compartments, moving from clinical, so symptomatic TB, to these more asymptomatic or subclinical states, and also assuming that test positivity, like culture positivity, would change over the course of these states. And then finally, this is a sort of study we're doing right now with the WHO, where simpler again here now, understanding that there might be culture negative and culture positive TB, not in this model representing, whether people are symptomatic or not. Not sure if that was the best decision, but was a desire to keep this model relatively simple. But in all these cases, trying to explode the single TB disease box to say, look, we're going to have differences, in this population with TB disease in terms of symptoms, in terms of rates of care seeking, which you think, right, those are going to be tied to symptoms, in terms of test positivity. And again, it's more complicated than we'd originally hoped. There's one final complication. So for all of these individuals, as I mentioned before, we now know that if and when they cure TB, either through treatment or through self-cure, that's not potentially the end of things. Some people will live on with post-TB lung disease. This is of lung damage that occurs during TB disease, does not fully resolve after treatment. So these individuals will have lower quality of life and higher mortality rates, potentially over the rest of their lives. So not everybody, but certainly enough people in this cohort that it's meaningful. And so this is a study we did about 5 years ago, trying to quantify the global burden of TB disease that included these post-TB sequelae. This is the component during the TB disease episode, and certainly on a per year basis, this is where most of the burden accrues. Right here, I'm reporting disability adjusted life years. This is a metric that tries to pull together some reductions in health due to shorter survival and reductions in health due to lower quality of life. This is the post-TB component. So per year, a much smaller contribution, but there's potentially sequelae sort of over the full course of the individual's life. So it really can add up to a big component. Okay, so at the midpoint, hopefully you're convinced TB is bad. You don't want TB. Like, I didn't tell you everything, but during the course of TB disease, people will experience increasing symptoms. Even if you get to treatment, those symptoms won't go away immediately. And treatment is actually kind of bad. Treatment requires 6 months worth of treatment. Well, 4 months is now, I guess, the shortest regimen available. And those regimens have their own side effects, so don't have TB. We know treating TB is good. Like, even though treatment is in some senses bad, it has these side effects and it takes a long time, it's better than not getting treated. Makes sense. Otherwise, we wouldn't treat people. We saw that most people don't have TB. If you took a well-mixed sample of the global population, if you took 1,000 people, odds are one person in that sample will have TB. So finding TB is hard. TB is bad. We want to treat it, but it's hard to find people. Okay. Also, clearly, we don't understand TB as well as we like. There's been a lot of, I showed you the modeling side of it, but, hopefully we're not just modeling out on our own, sort of divorced from real evidence. This is all tied to new sort of natural history findings that are coming out of these trials or observational studies showing us that, I want to be careful because some of these things, people like HIV is a new disease. Like everything we've learned about HIV, we've learned over the last, 30 years? Something like 40 years, probably 40 years. TB has been around, not been around for 100 years or 1,000 years. It's just been around, right? And so a lot of what we know about TB can be found in publications that came out in the 1910s or the 1970s or the 1980s. And so some of what we're doing here is actually rediscovering things that were mentioned in the literature a long time ago, but certainly weren't reflected in the models people were using to, understand TB over the last 20 years. But still this question, who has TB disease? So in reality, most people who we find with TB are diagnosed through passive detection. That is, people get sick, they feel sick, they turn up to a health center because that's where you go when you're sick. A clinician, elicits their symptoms, thinks that maybe those symptoms are consistent with TB. They give them a TB test. And then at some point they decide, okay, I think this person has TB, I'll put them on treatment. Okay, that's how we find most TB. Certainly there is active case finding where we go out into the community and try and find people with a TB. There'll be people who are tested because someone in their family has TB, right? Then we would sort of test all the close contacts. But most TB diagnoses happen because someone gets sick and they go to the health center. So, it's important that happens. Problem is that most routinely used TB tests are really, really bad. Like poor sensitivity is like a polite way of saying it. But so I started working in infectious diseases in HIV. And HIV, we have like a tiny little piece of card that you can kind of use to, so put someone's blood on it and wait for like 90 seconds. And the test itself, like this piece of card costs nothing, basically. And the sensitivity is like 98%, specificity like 98%, right? 99%, like 90. So really good. So up until about 15 years ago, the most common test we had for TB was sputum smear microscopy. Compared to all the tests we have today, it's still like one of the easiest to use. All you need to do is to get someone to cough up, to expectorate. You take some of that sputum, you put it on a slide, you stain it, you look at it under a microscope, and you count the things that stain up with the right color for TB. Okay, that process might take, I guess if you were doing it all while the patient sat there, it would be pretty fast. But most of the time, the fastest turnaround is going to be like an hour or two. Like it's not the clinician doing it; it's probably someone else doing it. And that was the fastest, best. We have, and it kind of still is the fastest, best, easiest we have. If you go to a routine kind of low-level health clinic, the easiest thing, the most likely thing they'll have is sputum smear microscopy. Amongst all people with culture-positive TB, that's going to find like 60 to 70%, right? So, you compare 99 or more sensitivity for these HIV diagnostics with our most easy to use test, we're getting sensitivity of, let's say, 70%. We're missing 3 out of 10. The argument was that, well, that's bad, but at least we're going to find those who are most infectious, which is right. So individuals with smear-positive TB are much more infectious than those without. It makes sense. They've got more bacteria in their sputum, and they also have the highest mortality risks. Individuals with smear-positive TB have higher mortality rates than those without, from very old studies where we didn't actually treat people. This is before we developed drugs to treat TB. We now have newer tests. It's fantastic. So we have cartridge-based PCR tests, again, compared to 99 or more percent. These tests will get 80 to 90% of all culture-positive TB. And remember, there's some culture-negative TB out there, so they'll get missed by all these tests. So for that reason, lots of patients get diagnosed clinically. I told you that in the US, like 20% of TB people we think have TB are diagnosed clinically. If we look sort of across low and middle income countries, and that's what this figure is doing, right? So just to orient you, we have the number of clinically diagnosed notifications per 100,000 on the horizontal, and the number of lab confirmed, so that's bacteriologically positive notifications per 100,000 on the vertical. On a log scale, this is deliberate. So this line going on the diagonal, this is the line of equality, where you'd say, okay, of all your TB notifications, 50% were clinically diagnosed and 50% bacteriologically confirmed. If you're above this line, you have more cases lab confirmed. You know, most countries are above that line, but for most countries, and particularly the highest burden countries, we're seeing 30 to 50% of all TB cases diagnosed clinically, that is without a positive lab test. And this is in our highest TB burden countries. I think globally it's about 40% of TB diagnoses are clinical diagnoses. So that's really, which brings us to the study I'm going to spend the most time on, which is a study that sort of thought, if we're using clinical diagnosis to try and catch the people who are false negative from our lab tests, can we really do that without creating false positive diagnoses? So diagnosing someone with TB, but that's a mistake. They don't have TB, they had something else. They came in because they were sick. So we're not saying they're not sick, but they have something else. And that's what so we focused on in the study. We wanted to understand really how many false positive and how many false negative diagnoses were being made globally. We used a pretty simple model of the TB diagnostic cascade. And so how TB diagnosis gets done will vary by country, but also a lot within countries, right? One clinic will probably do it differently to another clinic, mainly in terms of how clinical diagnosis is done. So, whether they are, particularly suspicious of TB, where you might just need to have a prolonged cough and then the clinician will be like, yeah, most likely TB, let's get you onto treatment. In another clinic, they might be like, much less likely to diagnose clinically. But in all cases, there's probably a lab test that gets done, either a sputum smear microscopy, right? I told you that was the easiest to use, but it's really bad sensitivity, or one of these cartridge-based PCRs, less culture done in low and middle income settings, certainly done, but just used less often. So there'd be an initial lab test. If that was positive, we say they have TB. If that's negative, they then have an opportunity to be diagnosed clinically. Lots of things go into clinical diagnosis. We're just treating it as a black box. Again, if they decide you have TB, then you're a clinically diagnosed case. If not, you go all through, and we don't actually observe you. No one counts the number of individuals evaluated for TB but not diagnosed with TB. I would love to get some of these data, but we don't have them. Okay, so that's the model we use, right? Like, simple model, not a dynamic model at all. This is just a flow diagram model. What matters in terms of the number of people being diagnosed or getting put into these three compartments is the fraction that start with TB, right? Kind of makes sense. The sensitivity and specificity of this first test and the sensitivity and specificity of clinical diagnosis. So this is a simple system. Thinking about, again, the fraction that start with TB, we don't know that number. We don't know it certainly very well. We know it's not 100%. Why would you even test people for TB if you knew it was 100%? You just put them all on treatment. Can't be 0%. Same thing would apply. We just say, well, no one here has TB, so let's move on. If we were wise, we might have stopped at that point, said, we can't do this analysis because we don't know this critical input. However, we did not let wisdom stop us. And so we just did the analysis a bunch of different times with a bunch of different assumptions about this value. We said, okay, run the analysis, fit all the data, assuming that only 5% of people evaluated for TB have TB, all the way up to, let's say, 50% of all people evaluated for TB have TB. Most reasonable people, or most people I would view as reasonable, I guess, right, would think that whatever the number is, it's between these two numbers. It's going to be higher than 5%. It's going to be less than 50%, most likely. My guess is actually closer to 5% than 50%, but it's going to vary a lot by country and a lot by setting. For the sensitivity and specificity of bacteriological tests, we took the published data, we put it into our analysis. This is a relatively well-known kind of quantity. In all of the diagnostic accuracy studies, these tests are compared to culture. So we have to acknowledge that there will be some people turning up with culture-negative TB. So essentially, we take all the sensitivities of these tests and adjust them down a bit to say, well, they're also going to be missing culture-negative TB. Okay. For clinical diagnosis, it's a little bit harder. There certainly were a bunch of studies done before we developed new tests trying to understand the sensitivity and specificity of the WHO smear negative TB diagnostic algorithm. This was how you were meant to diagnose people if they were negative on a sputum smear microscopy. And you can see the results of those studies in these little sort of X's. And right, they sort of span the board. I mean, so apart from this study, to me, these studies say you can't have it both ways. You can't have clinical diagnosis that is both highly sensitive and highly specific. You can have clinical diagnosis which has high specificity but low sensitivity. You can have clinical diagnosis that has low specificity but high sensitivity, but you can't have it both ways. There's no sort of magical clinical diagnosis. Otherwise, we wouldn't need those lab tests in the first place. We just sort of look people up and down and decide. So in this analysis, we said that an individual country could be anywhere on one of these lines, but it needs to be on the line, right? So the blue line was our main analysis. And so it said, basically what I just said, that you can either have high specificity and low sensitivity, or, low specificity and high sensitivity, or indeed any combination as long as it lies on that ROC curve. And then simply we fit that simple model to the data for every single country, acknowledging the fraction of people who are diagnosed clinically versus bacteriologically positive, the fraction of time people were diagnosed with smear as compared to one of these new cartridge-based PCRs, and also acknowledging the fraction of people tested for TB who had HIV, because we know that that sort of impacts the sensitivity of these tests in a bad way. And so this is where we got. So these are our main results. Looking globally, not digging into the country-specific results, just the numbers of true positives, people evaluated for TB who actually had TB, right? This is not something we can see in the data. It's not like countries report the number of true positives. They just report the, just people diagnosed with TB. We don't know whether they have TB. So we put data into the blender and we got inferences out the other side. So these are a combination of data and all the assumptions I just described. So about 5 million true positives, about 1 million false negatives, right? So these are the people with TB. About 2 million false positives and 15 million true negatives. So these are the people without TB. So, in terms of algorithm sensitivity, if we think about this whole diagnostic algorithm as just a single test, right? We can say that overall sensitivity, which is the true positives divided by the true positives plus the false negatives, is 83%. If you get evaluated for TB and you actually have TB, there's an 83% chance that you'll get diagnosed with TB. Specificity, okay? If you don't have TB, but you get evaluated for TB, what's the chance that you get a negative diagnosis, a correct negative diagnosis? It's 88%. For a clinician, so these predictive values are more important. So negative predictive value, that is to say, I diagnose you as not having TB, what's the chances that you actually don't have TB? Like that negative diagnosis is correct? 94%, right? That's only 1 in 20 getting it wrong. In terms of positive predictive value, that is, I diagnose you as having TB, what's the chances that you do actually have TB? 70%. And then finally, so just adding up over all these test results, just what fraction of all test results are correct? That's sort of 87%. So, 9 out of 10 approximately, right? Again, compare this to the 99.9 something percent for HIV. So what this is saying is, amongst all the people sort of tested for TB or evaluated for TB in low and middle income countries, about 1 million are getting a false negative diagnosis every year. They have TB. They do the thing you're meant to do. You feel sick, you go for care, but they get a negative diagnosis. Now, this is something which the TB community is aware of, and it's a focus of a lot of programmatic effort and innovation to try and reduce this number. We know that people with TB, a lot of these people, they'll turn up again. They'll have ongoing symptoms and they'll return to the clinic, 2 weeks, 2 months, 6 months later. In that intervening time, they'll have ongoing lung damage. They'll be more like, well, they have ongoing risk of transmitting to TB to their household contacts and other in their workplaces, and they could die. They could never get back to care. So although a lot of them will eventually get diagnosed, this is still a big problem for TB. About 2 million false positive diagnoses. And that's obviously 2 million is 2 times more than 1 million. This is news, I think, in that, you go up to anyone who works in TB and say, can there be false positive diagnoses? And people will say, of course, must stand to reason. But you don't get much further than that. If you went to a TB program and said 1/4 to 1/3 of all your TB diagnoses are incorrect, those people don't actually have TB, yet you're putting them on a 6-month regimen to treat TB, you would get likely a pretty cold reception. Of course, this analysis was built on both data and assumptions. Those assumptions here are pretty important. But we also found the results were pretty robust. That is to say, the fact that we might have more false positive diagnoses than false negative diagnoses held up in all the different ways we kind of shook the model, changed the assumptions, changed the model structure just to test that this was a real answer. So we don't know that it's 1/4. We don't know that it's 2 million or 1 million, but it's something in that range. For patients, or for, I guess, clinical care, we know that TB diagnosis is hard. Clinicians know a lot of the things I told you. They know that TB disease is bad. They know if they don't treat it, it gets worse. They know that the tests we have to diagnose TB are really, again, bad sensitivity. And so they're faced with this clinical conundrum of they got people who look like TB, they got the signs, they got the symptoms, but the test is negative. What are they going to do? In a lot of cases, they will treat that individual for TB just under the idea, not that they're sure that they have TB, but it's the best thing to do. Better to treat that person for TB than to not treat them and potentially miss some people with TB. So the last thing we want to do is see a lot of clinical diagnoses. And I must say, I didn't highlight it, but actually I'll go back just quickly. Okay. Here, so in our estimate of the number of false positive diagnoses, most of them, over 70% are coming from clinical diagnosis. Okay. So, right, you could try and reduce clinical diagnoses or false positive diagnoses by stamping down on clinical diagnosis. But it comes to this point of, trying to do right for the people who have TB and trying to do right for the people who don't have TB. So if we make TB diagnosis more stringent, unless we have new diagnostics, we're going to miss more people who have TB. This is kind of the clinical conundrum. So we don't want to just say do less clinical diagnosis because that could cause actual harm. What we need is ongoing research to develop better, easier to use diagnostics. I say better, it implies a better sensitivity, but also easier to use. Like a lot of people actually have trouble producing sputum, particularly when they're quite sick. Individuals with HIV, young children, these are people who are very hard to diagnose. We need tests that are able to work with those population groups. At the same time, we need to know about this balance between getting it right for people who have TB and people who don't have TB. So I think for clinical care, it's nuanced. Right? For surveillance and burden estimation, it's also nuanced, but it's easier to see that what we're doing right now might be wrong. Because for most countries, the number of TB diagnoses, like notified TB cases, is a key part of burden estimation. In some countries, they'll take that number, multiply it by something, and that is the estimate of incidence. Right? Under the assumption that some TB cases are simply going to get missed. The individual will either die or self-cure, and so they'll never get notified. So we'll inflate notifications to get to our estimate of incidence. If 1/4 to 1/3 of all TB notifications are actually wrong, they don't have TB in the first place, then it's harder to use that to understand incidence trends. Okay, and so certainly in some countries, they have good vital statistics data in terms of who dies from TB. And so Brazil, we can be reasonably confident that their sort of numbers of TB deaths that they report is correct. So what that means for Brazil is different to another country where they don't have really good death estimates, but they might have a TB prevalence survey. And so all of the surveillance estimates and the burden estimates kind of condition on different data sources on a sort of country by country basis. And so if there are a lot of false positive diagnoses, what it means is going to be different setting by setting. And certainly this is, an area where more research is needed. Like, we shared our results with the WHO as we were developing them, knowing that they might not like them, and it was better to understand that position before we published. And they accepted that there was something there. It's unclear to the extent to which they can, they're dealing with a lot of things. And if you change what TB epidemiology is at a particular point when a lot of funding is sort of draining out of the area, it can just be politically, it's not the best thing for them. But anyway, certainly, again, more research needed to understand these things. Okay. Thank you. Yeah.
I have two questions. The first is, what role did the screening test that we have in this kind of model framework with PPD and IGRA?
Yeah, so in the US, if you are evaluated for TB, you'll probably, there's probably a reason for that. For people who are close contacts, they will not only be evaluated for TB, they will get an IGRA as well. In low and middle income settings, we're rarely seeing people getting certainly not an IGRA. So IGRA is essentially a blood test for an immune marker of TB infection. This goes back to the start of the talk where I said that, maybe some people don't have viable TB infection anymore. Yet even if you can clear TB, you'll probably still test positive on that IGRA. So IGRAs are expensive. So they're not going to do them that much. Even PPD, that's just typically not done. Certainly, the way we take people who attend a clinic and decide to evaluate them for TB, to actually do a TB test, we didn't start at that point in the model. In our model, we said, okay, we're going to start with the number of people evaluated for TB. But how you decide to evaluate them for TB is going to be really important. The more people you decide to evaluate for TB, you're going to have more people who don't have TB in that pool. But you're going to catch more of the people who do have TB. And so you're going to essentially make more false positive and more true positive diagnoses. Yeah, question there and question here.
My question, I don't know all the models you showed, how does being exposed to someone else that's potentially coughs around you and what's in non-TB disease transmission models would be like a reinfection or something like that. Does that ever, does that impact people's moving from latent or any of the other versions of the model? Do people getting exposed again, move them from bottles to compartments?
Yeah, so the understanding for TB is that it's kind of hard to catch TB. You need to have prolonged close contact to get infected. And so that separates it from a disease like COVID or the flu where, it can be spread through more transient and distant contact. For someone who's already infected with TB, the understanding is this is based on the best estimate evidence available, but still slightly weak in that it's not sort of a trial or anything like that. But the estimate is that if you're previously infected with TB, you kind of have a fair bit of partial immunity. You can be reinfected, but the likelihood that new infection would go on to produce a kind of reasonably rapid progression to disease is a lot lower. And so that becomes important if we think certainly about people with repeated exposures. There will be a higher incidence of TB, but we can also think about people being infected with different strains, right? Because if you had no risk, then being infected with a drug-sensitive strain is kind of protecting you from, being infected with drug-resistant TB, which would be great. We know that, we believe that most drug-resistant TB these days is actually transmitted rather than people acquiring resistance during treatment. But so it's somewhere in the middle. It's not perfectly sensitive, but it's not perfectly protected. I think the most commonly used estimate is that there's like 80% partial immunity, which is pretty good. We would love to have a vaccine with that level of protection. They're trying, there's TB vaccines on the rails. They're coming. They might come in like 5 years' time. Hopefully they'll work enough. But 80% would be high efficacy for those vaccines. I think like the market leader is like 50% efficacy. Yeah, so I went off on a sidetrack there, but yeah. Yeah, question.
I'm curious if in previous modeling efforts where they don't include culture negative TB, how much of an impact including that might be making on future TB cases. Is there any understanding from the American studies on how infectious culture negative individuals are compared to culture positive individuals for TB?
Yeah, that's a good one. And so it's useful to think about how the system changes when we apply interventions to it. So a model that might be good descriptively might be biased when we come to sort of test interventions. And so here the situation is, the intervention we would probably look at is active case finding. If you go out into the community and try and find people with TB, if many people have culture negative TB, yet are in some way, mild way, still infectious, that will reduce the, impact of active case finding compared to what we would see in a model where there was only culture positive TB, right? Because that's some part of all transmission is coming from a group that won't test positive on our tests and may also not feel like they have TB. So that would be the impact there. And so, we're actually doing a study right now looking at sort of the potential impact of expanded active case finding. And it's a big question, like, are you going to find the asymptomatic individuals? Are you going to find the culture negative individuals? Even in active case finding interventions, there are still going to be some people diagnosed clinically. So they will find some of that culture negative TB. But yeah, it definitely matters.
Maybe we'll get our last question.
Okay.
When we're thinking about false positives, presumably some of these people are being tested because they've had contact with an infectious person, but some of these other people have symptoms that they're presented with. TB is not the actual cause of the symptoms, but they're being tested as positive. Or first part of my question is, in general, what is the actual kind of etiology of these symptoms if it's not TB? And then my second part of that is, do you have kind of a sense for what is the cost of these false positives, either in terms of delayed care for primary treatment or potentially like bystander selection if they're getting a series of vaccine for 6 months, and whether these infections are actually a bacterial lung infection, if that's drug resistance?
Yeah, no, it's a great question. I mean, the shortest answer is we don't know. Like, there's been limited studies on false positive treatment because, right, most people in that group will probably have some transient respiratory infection. And so they'll get better when we treat them for TB. And that's what we want to happen. So if you give someone TB treatment and they get better, then don't change what you're doing, right? Yet we might be treating them and they don't need to. So that's a cost. Some people will have pneumonia. Some people will have COPD or other circulatory system illness. Some people will have lung cancer. And so we did a study in Brazil where we looked at all the people who were recorded as a TB notification, but had a change of diagnosis, was what it was called. So that means they were diagnosed with something else. They said they had TB and then they changed it somewhere else. We saw in that group of people much higher mortality rates than amongst the people who didn't get a change of diagnosis, right? And you've heard me saying TB is horrible, not only when you have TB, but afterwards. These identified false positives actually had much higher mortality. Now, the issue there is, well, the only way you change a TB diagnosis is if someone is getting worse. So we found that a lot of these people actually had lung cancer, but they were only probably a tiny, part of the false positive diagnoses and selected for getting ill. So makes sense that they had higher mortality because the only reason they changed the TB diagnosis was that clearly something was wrong here. So yeah, great question. And a great area for more research. Okay.
Final round of applause.
Yeah. I thought you were asking me to,
No.
to provide a final report.
No.
Yes. Yeah. Okay, thanks guys. Also, I'm based here. So if anyone wants to follow up on any of these questions or discuss other stuff, email me, call me, find me after the meeting. I sit there, building 1. So, you know, building over from CCDD, but certainly very local and very happy to talk. Thanks.
Thank you.